initial evaluation of a child with congenital hypothyroidism is focused at looking at the cause of congenital hypothyroidism, its impact and likely course. Two tests which give us a big clue include the ultrasound of the thyroid, which tells us whether the gland is there or not, and the thyroid nuclear scan, where a dye is injected which is bound to technetium, which is a radio tracer, which goes then and gets concentrated in the thyroid. So while ultrasound gives us information about the structure of thyroid, the thyroid nuclear scan gives us information about the function. The combination of the two is able to provide us information about whether the gland is formed or not, whether it's functioning or not, and whether the treatment is required for a long time. While these tests are important to guide us in terms of long-term treatment, we should not wait for the results of these tests to decide about long-term treatment. We should start the treatment within the first 2 weeks, and if these tests are not available, we should not wait for them and delay the treatment, because delaying the treatment can have significant impact in terms of long-term outcome. The other workup of a newborn who has congenital hypothyroidism, including assessment of hearing, because many children who have thyroid disorders also have hearing issue. Looking carefully for other possible malformations, including the heart defect, and sometimes looking for the X-ray of the knee to see whether the epiphysis is formed. The thyroid hormone treatment is done using the thyroxine or T4 tablets, which is only available in a tablet form across the globes, and liquid preparations are not available. We should crush this tablet between 2 spoons and then dissolve it into the expressed breast milk from the mother and give it to the child. Ideally, there should be a gap of around 4 hours between the intake of feed and the medicine, and we should not have any other feed in the next half an hour. This, however, may not be possible in the neonatal period. If a neonate vomits the medicine within the first 15 minutes of intake, the medicine should be repeated. The most important part to remember is that this medicine is to be given daily till the time we are sure that we do not need to continue the treatment. The initial aim of treatment is to suddenly build the thyroid hormone level. So we start at a high dose of thyroid and then titrate it according to the results after 2 weeks. The thyroid function test, mainly the free thyroid hormone and the TSH, are done at 2 weeks, then 4 weeks, and then subsequently 1 to 2 months, especially in the 2-year period where the brain development is most important. The aim of treatment is to maintain free T4 in the high normal range and TSH in the normal range. Some newborns who have very severe congenital hypothyroidism may have a TSH level which may be persistently high, but if the FT4 levels are normal, we do not need to increase the dose. In most cases, the treatment is lifelong, but if there are suggestions that this could be a transient hypothyroidism, the thyroid dose is not increasing, mother has got hypothyroidism, we are able to get the levels normal very quickly and they stay normal, we may give a trial of stopping thyroid hormone at approximately 2 to 3 years of life. We do not do this within the first 2 to 3 years because that is the time when the brain is developing and we don't want to put the child on risk. At 2 to 3 years, if we stop the treatment and the thyroid functions remain normal, there is no need of further treatment. On the other hand, if the reports again show that there is deficiency of thyroid, definite treatment is required. The outcome of neonates with congenital hypothyroidism who have been identified at a correct time and treated within the first 2 weeks of life with normal maintenance of thyroid functions is very good, but if there is a delayed diagnosis, the outcome is definitely compromised, with every week of delay causing significant impact in terms of overall development.